there's some important aspect, which is counseling and informed consent. The patient should be informed about all the complications of the laparoscope, including entry techniques and conversion to laparotomy, and the risk of internal organ damage during the procedure. And this is, of course, related to the characteristic of the patient. Some have low risk, others have high risk. And she should be counseled also about the post-operative complications, including hernias, infection, although they are rarer than the laparotomies. For the operator, individualized risk assessment based on patient characteristics, medical history, and preoperative evaluation is critical for minimizing complications, and it will protect the surgeon from litigation for some extent. I will talk about intra-complications, pneumoperitoneum complications, energy devices risks, internal organ damage, immediate and remote post-op complications. Intra-complications, how to avoid. First, you have to choose the right entry point on the abdominal wall. Choose the right way, that's either direct entry, venous insufflation, or optic trokers. And this depends on the surgeon preference and skill. And the ancillary trokers inserted under pressure of 20-25 millimeter mercury. Then we decrease the pressure to either 12 or 15 millimeter mercury while working. Vascular complication. During entry, we have the inferior epigastric vessels and the superior superficial epigastric vessels. The transillumination with the scope, it shows us the superior epigastric vessels, but the inferior epigastric vessels, we have to know its origin and anatomy, which is usually medial to the round ligament. Also, there's something good, the superficial epigastric vessels can guide us to also the pathway of the deep epigastric vessels. They go with each other. So vascular complications, they are easy to be diagnosed, treatment by suturing or coagulation. This is back to anatomy. This is the aorta, common iliac, external iliac, internal iliac. The most devastating vascular injury is the aortic injury. And it's always said it's surgeon fault. And it's really devastating. When it happened, what to do? The field will blocked with red. You can't see anything with aortic injury. So knowledge of the anatomy is vital to avoid major complications. For those who go through the umbilicus, it's good to know that by anatomy, the umbilicus is slightly higher up from the bifurcation of the aorta. So you can avoid the injury to the aorta, to the bifurcation of the aorta. So most of the gynecological procedures, entries with primary trokers are at the level of umbilicus, which is at or slightly above the aortic bifurcation. For obese patients, the umbilicus is lower than the bifurcation because of the redundancy of the abdomen. Injury of the aorta, common iliac artery, inferior vena cava, or common iliac veins are devastating and mostly operator fault. Some series say that. Treatment, if you have experience in dealing with vascular injury, go for it. If not, convert to laparotomy and make pressure with packs till your vascular colleague come. Now I'll talk about internal organ damage, organ injuries or damage. It may happen, especially if there are abdominal scars, but less in virgin abdomen. The only structure which is adherent to the abdominal wall is the falciform ligament. It's the only structure, and it's usually bloodless. If there's anything adherent to the abdominal wall, it's adhesions, either bowel or just adhesions. Also in midline, incisions, the incidence of adhesions increase. It may reach up 25 to 50%. So you have to change the port of entry. Usually you go for Palmer's point or the area between the xiphoid and the umbilicus upwards, or go for Hasson's technique. So treatment, if bowel injury occurred, If the surgeon again experienced and managed such a complication, he can progress for suturing. If not, just stay calm and call your colleague. So, knowledge of anatomy again here is important. And the only structure, as I said, is adherent to the abdominal wall is the falciform ligament. Now, regarding complications of pneumoperitoneum, which is peculiar to the laparoscope, it's cardiopulmonary effect, either from inflation of the abdomen and pressure on the lungs and heart. Also subcutaneous emphysema, which is not considered risky or serious. It may cause some pain after surgery, but not serious really. And venous gas embolism. Venous gas embolism occurs when we go by venous needle, make some injury to a vessel, and you insufflate. This is dangerous because if you insufflate in a vein, a big vein, it may go back to the heart and may make right heart block. Now, when we talk about laparoscopic complications, we have to talk about energy devices in laparoscope. The most common and known energy devices for us is the monopolar and the bipolar. The monopolar, we know it's the yellow pedal and the blue pedal. The blue for coagulation, the yellow for cutting. This is basics. In a series done by the PubMed maybe 10 years ago, it shows that up to 80% of junior gynecologists, they don't know basics of energy devices. So it's important to know about energy devices. Now, why do we use energy? We use energy for vessel sealing or hemostasis. We can use either also clips or staples, but they are more expensive, more time consuming. So we'll go for energy devices. What about monopolar and bipolar? In laparoscopic gynecology, monopolar is preferred to be just used for cutting, the cutting mode, because to use it for the coagulation mode, it will not coagulate. It just will coagulate a diameter about just 1 millimeter. And it will give a great amount of energy and heat, which is risky. So, to coagulate is by bipolar. Also, in monopolar, the current, the electrons, will pass through the body of the patient. In bipolar, the current is just passed through the jaws of the instrument. Another devices like the ultrasonic technology, it's not electrodes, it's vibration of crystals and mechanical sealing. Now, all laparoscopic energy devices sources can cause lateral thermal damage. This is opposite to some companies which try to market that their instrument doesn't cause any lateral damage. All the energy devices, they cause some lateral damage to some extent. So, possible mechanisms of energy are mistaken target application, straight current injury due to defective insulation. This is important point. The instrument where we cut or coagulate should be insulated all through, just the tip should be active. Now, sometimes because of multiple sterilization, this isolated layer may be broken. So, and the instrument is outside our field. We just focus on the tip of the instrument, and the other part, they are outside of our field, and the insulation is broken. It may cause also some injury. So, if you watch your video multiple times, you will not spot or see any problem while you are working, because it's outside your field. Now, also another mode of injury, direct coupling, that the active electrode touch another instrument, it may cause injury, and capacitive coupling. This occurs in if we use more than one kind of trokers, like combined metal and plastic. and it's said with single port injuries, the single port it's more evident. Now, an alternative site burns due to defective in the circuit, especially in the monopolar. But now most the instruments and machines, they can spot if there is any break, it will not work the machine. So we can overcome this. Now, internal organs injury, I talk about just the ureteric injury. The ureter, is it an enemy or a friend? If we don't know about it, it's an enemy. If we know everything about it, then it's a friend. Some facts, 70% of ureteral injuries are diagnosed post-operatively. This is important because usually the ureter is injured by thermal injury, and thermal injury make late presentation. Maybe presentation will be 7 or 14 days later, but transection or direct cutting of the ureter will show on spot. Symptoms of ureteral injury is flank pain, tachycardia, fever. Now, it's said also in sub-series that 90% of ureteral injuries occurs during gynecological procedures, but not only by gynecologists. This is important. Now, during hysterectomy, the most common site of injury, as my colleague just mentioned, it's near the uterine artery. So, the solution, with the uterine manipulator, we push the ureter upwards. Now, the usual distance between the ureter and the cardinal ligament or the cervix is about 1.5 centimeters. If you push with the uterine manipulator the uterus upwards, this distance becomes more, maybe it reaches about 4 centimeters. So during hysterectomy, we can push using the uterine manipulator will decrease this complication. Also, scrutinization of the uterine artery to see it and coagulate it precisely can avoid this complication. This is also, we have to know the anatomy again of the ureter. The abdominal, it's tubular structure, it's about 30 centimeters in length. It has abdominal part and pelvic part. Another common site of injury during hysterectomy of the ureter is the site of the pelvic brim. While we do adenexectomy, when we cut the ovaries or coagulate, it's a common site for injury. And at the site of the uterosacral ligament, if there is endometriosis, deep endometriosis, it's also a site for injury. How to avoid ureteric injury? Knowing anatomy, pushing the uterus upward by uterine manipulator can increase the distance, and careful scrutinization of the uterine musculature. Another common site, I say that about at the pelvic brim. So, knowledge of the anatomy and landmark of the ureter can prevent and help in the diagnosis of the most ureteral injuries. The ureter is a delicate organ, must be handled with care, preserving the adventitia, which is the serosa of the ureter, which contains the blood vessels of the ureter, should be handled with care to prevent necrosis. And some rules for dissection, visual identification of the ureter, exposure, apply divergent forces, and use energy with caution. Use energy bipolar with small bursts. Also regarding the ureter, the radicalists, they know that malignancy, they push the ureter to the sides of the abdomen, while endometriosis is pull it to the medially. Now, post-op complications, infection, thromboembolic events, respiratory complications, and hernia, but less than laparotomy, of course. In conclusion, laparoscopy is generally safe and associated with lower morbidity compared to open surgery, but it has its own and peculiar complications. Surgeons should maintain a high level of technical expertise, adhere to strict safety protocols, and prepare to manage any complication that may arise. And thank you.